Okay, we will start. Доброго вечора, українські радіаційні онкологи. Слава Україні. Черговий раз дякуємо, що приєдналися до Case Review with ASTRO Experts для України. And today we have a session on a very hot topic nowadays, re-irradiation, and we are honored to have an internationally recognized global expert on radiation, Dr. Nikolaus Andratschke, professor at the University of Zurich, and a Ukrainian speaker is Dr. Marina Sokolovska, an associate professor at Lisot Hospital in Kyiv. Professor Dr. Nikolaus Andratschke is a vice-director and senior physician at the Department of Radiation Oncology, University Hospital Zurich, with clinical expertise in neuro-oncology, thoracic oncology, stereotactic radiosurgery, and MRI-guided radiotherapy. He has led and contributed to numerous advanced radiotherapy initiatives across Europe, included, of course, re-irradiation. He completed his medical training and doctorate at the Technical University of Munich, followed by a postdoctoral fellowship at the MD Anderson Cancer Center. And his academic milestones include an appointment as titular professor at the University of Zurich. Professor Andratschke's research focuses on adaptive radiotherapy, AI-driven treatment planning, oligometastatic disease management, and re-irradiation. He serves in key leadership role within the ERTC, included head of radiotherapy quality assurance at National PI for multicentric trials. He is also a co-chair of the Global Harmonization Group and a frequent reviewer for leading oncology journals, including Lancet Oncology, Green Journal, and other. He is a recognized global expert on re-irradiation and authored and co-authored many manuscripts on this topic. So thank you so much for teaching us today. And our second speaker does not really need an introduction in Ukraine. She is one of the leaders in radiation oncology in Ukraine with more than 20 years of experience in this field. Dr. Marina Sokolovska is an associate professor at the Shupik National Medical Academy of Postgraduate Education. She holds an MD with honors, a PhD focused on radiomodification in oral cancer, and a master's in public management. Dr. Sokolovska has served as lead and sub-investigator in international clinical trials and is a regular speaker and organizer at national oncology conferences. With help of Help Ukraine Group, she completed ASTRO contouring workshops, the ASTRO leadership course, and attended the ASTRO Congress and ASTRO annual meeting in 2024, and completed the observership at the Christie, United Kingdom, and Miami Cancer Institute, United States. She is committed to advancing radiotherapy research, education, and mentorship in Ukraine. So we are grateful to your efforts, Dr. Sokolovska. So we are looking forward to learning about re-irradiation. So Dr. Andratschke, the podium is yours.
Ruslan, thank you very much for this very, very kind introduction. That's very well appreciated. And Marina, thank you very much for the invitation to speak on this topic. And I will try to stick to the time. So Ruslan and Marina, please interrupt me if I'm taking too long so that we can really focus on your cases afterwards as well. I would like to give an overview of re-irradiation in clinical practice and also try to start out with some general considerations on re-irradiation, and maybe then also make very specific points when it's regarding the organs at risk or planning, and would like to use thoracic re-irradiation as a prime example. And in the end, also give some overview of the current activities within Europe and also internationally. Well, we need to be aware, and that's why I did not prepare a multiple choice question, but afterwards open-ended questions so that we can have a discussion every now and then during my talk. We need to be aware that, of course, it's a very attractive subject and more studies are being published, but most of those studies are retrospective case series, single institutional series, and still some prospective trials. But if we then, try to move forward. But if we then try to really get a good picture, we have randomized controlled trials available, but mostly in the brain, head and neck and breast area, and not in any other area or in bone with palliative radiotherapy. But we are really lacking higher level evidence in other areas of re-irradiation. So basically, a lot of the knowledge we're talking about is from retrospective series, which reflects more or less experience and not so much really validated prospective evidence. Now, first of all, I would like to really discuss about the clinical scenarios of re-irradiation, because a couple of years ago, we set out to really define what re-irradiation means. Because if you look at all those studies, it's not sometimes really clear whether it's really in-field re-irradiation or whether it's overlapping or whether it's just repetitive or repeat irradiation within the same organ. So we try to disentangle the clinical scenarios. So here you see a full overlap, and maybe the tolerance of a single course RT may already exceed or not the tolerance of the organs at risk. And then with the second re-irradiation, you may or may not have concerns of toxicity. But here you really have an in-field recurrence, and the question is it a local recurrence or is it just a new primary in the near vicinity? Then we have the situation with no immediate overlap of the two volumes, and the dose may be within the single course of radiotherapy, but it may exceed the cumulative dose in the central organs of interest, like the bronchial tree. And then the third scenario with a re-irradiation is that it's within the same organ, and it may or may not exceed the dose of a single course of radiotherapy, just looking at the mean lung dose or the mean lung dose of the left lung parenchyma. So three different scenarios, especially with the cumulative doses, there may be also a difference in how we should call those scenarios. Then, of course, we need to address the question of the time interval. Is it within a certain period of time of the previous radiotherapy? And then it definitely plays a role if it's really a local recurrence of the same tumor, or whether it's a new primary or a lymph node metastasis, as here in the example. And we always need to question what happens in this interval. So is there really a recovery? That's one question. The second question is, did the first irradiation have some long-lasting effect at all? But for palliative re-irradiation, this may still be a valid situation if it's within 2 or 3 months. We need to palliate bleeding or whatever. So we really need to look at this. And then, irrespective of the previous interval, we need to ask whether there have been side effects from the previous treatment, if there is chronic toxicity or persistent toxicity. And it's really important to then also define the oncological goal, whether it's palliative versus potentially curative. And here, still a risk-based high-dose re-irradiation may be possible. Now, we're just wrapping up an article and try to depart from the nomenclature of serial and parallel organs, because there's much more to it than just this general concept. But I still like to stick to it because it's very illustrative and it's still very much in our minds from how we were trained in radiobiology, but it may change over time. So here it's really important with those organs, tubular organs like esophagus, proximal bronchial tree, we are more or less looking at like serial organs or endpoints that are relevant, that if one of those elements is destroyed, then we can have a serious or significant toxicity. It may be influenced by volume, but the most driving factor is certainly the cumulative dose to that volume. On the other hand, we have organs where it's not that important when some part of it is destroyed because we can compensate, like in the lungs or in the kidneys, but still here there may be a situation where at some point the cumulative volume of the lung is exceeded and we may see impairment in lung function or maybe even also increased risk of pneumonitis. So that's why we've tried to come up with a consensus. What is re-irradiation? And the major differentiation is type 1 versus type 2. Type 1 refers to the first clinical scenario where it's all about the overlap of the irradiated volumes, whether or not we have concerns for toxicity from cumulative doses. The second time is really where the volumes do not overlap, but we have spillage of dose, either from the two irradiations or if it's a cumulative effect over several irradiation, but where the spillage and the overlay of the dose really raises a concern of toxicity. And this is contrasted to a situation where we have repetitive organ irradiation and where we have no overlap of irradiated volumes, and at least from what we currently know, have no concern of toxicity from cumulative doses, and the target volumes are in the same organ. What's really important, we are looking currently in the lungs and at all our patients with thoracic re-irradiation. And what we see that, especially with regards to pneumonitis, this repeat organ irradiation may put our patients even at a higher risk of pneumonitis compared to the type 1 or type 2 re-irradiations. So this is a phenomenon where we might need to reconsider whether or not repeat organ irradiation is really not of concern of toxicity. So it's important to understand that this is a concept that has been methodologically developed in a discussion of experts, but I think in the long run, this also needs some validation with clinical data so that we really classify our patients according to this and then look at what the real effect is. Important was that if we report on re-irradiation in scientific studies, we have a standardized nomenclature. And this is summarized here. It's based on a hierarchical question. And actually, the first question, is there a geometric overlap? Yes or no? If it's a yes, it's type 1. And if it's a no, then the major driving factor, is there a concern for toxicity from the cumulative doses? And if so, it becomes re-irradiation. And then the third question is, if it's no, is it located in the same organ? If yes, then it's a repeat organ irradiation. And as I illustrated here, at some point, it's possible that a repeat organ irradiation may transform in a type 2 re-irradiation from if it's really a repetitive irradiation in the same organ, for example. Also, we thought that repeat irradiation somewhere throughout the body is also important to state because we need a nomenclature if a patient comes a second, third, fourth time for re-irradiation in the lung, somewhere in the bone, somewhere in the brain, that we really have a clear understanding what we mean by repetitive irradiation. Maybe a few words about patient selection. The most important factor to me is really the decision-making, palliative versus curative dose. And I especially put dose in here and not palliation versus curation. I think we need to be aware that re-irradiation currently still needs to be considered in most instances as a palliative measure. So we have occasion cases where we see long-term survival, but we're still missing the data whether re-irradiation, and especially in-field re-irradiation, really is a curative measure, even if we go give high-dose re-irradiation. And the important point I want to make is if we need especially do re-irradiation of a local recurrence, so a tumor that has recurred as after a first course of ablative or high-dose radiotherapy, we would need at least, if not more dose than in the first series to make sure that we have some chance of cure. So here it's really the distinction to give high dose versus lower palliative doses. And it's a very nice study on thoracic palliative re-irradiation, and they really come up with quite some intuitive factors. So these are not validated factors, but these are factors that we really can use as a guidance. And if we look at this, like a KPS of at least 80 confers to a longer overall survival, no extrathoracic disease, no distant metastasis, a smaller volume, time interval to recurrence more than a year. So all factors that point to maybe a more beneficial phenotype of this situation. And very important is that our treatment intent needs to be defined interdisciplinary with all disciplines involved. And afterwards, we really need to transparently communicate this with the patient. And it may be that we get into a situation where we opt for high-dose re-irradiation, but the patient is not willing to take the risk, and we may need to adjust to a real palliative dose or no radiation at all. Or it can be also the other way around, that we communicate both possibilities and the patient is willing to accept a risk we most of the time have to qualitatively judge for longer-term local cure. But important, these are just general clinical factors as a guidance, and optimally we have an outcome-based modeling where we can try to predict in which risk category a patient belongs. And this has been done mostly also on retrospective data, but at least we have it available for head and neck re-irradiation, for glioblastoma, and more specifically also for nasopharyngeal cancer. So I think it's quite relevant to try to classify, or at least try to get an impression for an individual patient in which category he or she belongs, and then use this also as a factor whether or not we should give higher dose re-irradiation. But again, we need more outcome data, and we need more modeling. And of course, we need validation on those on other data sets. And more importantly, it's not so much about that we really mirror those curves, but it's more about that we see, okay, can we see the same risk categories for our patients? And then probably we might, on an institutional basis, come to different median overall survival for the different risk groups. This is something similar we have observed with all the risk scores for brain metastasis, for example. Maybe also a few concluding words on the patient selection. So I already put out this. We need to define the treatment intent. But more importantly, we will have patients with short life expectancy, and we might still be able to have some symptom control if we deliver radiotherapy, even in situations where the cumulative doses might be excessively high. But here, the important point is if we're talking about long-term concerns, long-term toxicities beyond 3, 6, 9 months, then still palliative radiotherapy may be valid as long as we are very careful not to induce unnecessary acute toxicity. I think that's a very important point. But for end-of-life care, it might still be a valid option. Now, there's a lot of discussion also about the efficacy of re-irradiation, and also always the question, oh, if we have irradiated once, we may have induced some radioresistance. The data is not fully clear on that, especially preclinical data is more or less missing. In the clinics, as I pointed out, if we do not give a higher dose than in the first course, it will always stay palliative, and the local control will not be, at least not be better as for the first radiotherapy. And in most instances, even with a higher dose re-irradiation, we sometimes stay below what we've given in the first course. So we cannot deduce from these scenarios that we have to deal with radio resistance, but rather with the problem that we are not giving high enough of a dose to the tumor. But we have some indication in the palliative setting, for example. So if we look at bone metastasis, here the comparison of re-irradiation with 1 × 8 or 5 × 4, the overall survival is similar. And more importantly, we have comparable response rates. And that's at least for a functional endpoint like pain, that's very important. So even though it's a re-irradiation and mostly with the same dose here in this setting, we have a pain effect in those patients, and sometimes even lower toxicity with 1 × 8 grade. So the efficacy is maintained and here I misspelled it, the efficacy is maintained for a pain or palliative endpoint. Now, this is again taken from the systematic review of palliative mediastinal irradiation, where I showed you the clinical factors predictive of overall survival. And here you can see the symptoms for which those patients have been treated. And there was a symptom improvement in 70% of those patients. More interestingly, sometimes there was a response duration of up to 2 years. So palliative re-irradiation, and still there were long-term responders and long-term effects. And if you look at here at the doses that have been given, there's an indication with the higher doses, the longer the duration of response, and possibly an impact on overall survival. But still, those patients were considered treated for palliative intent. But we have again an effect, and those doses are lower than those given in the previous setting. And if we look at the toxicity, grade 2 or higher, that's also reassuring that it's not a complete excessive toxicity. So here we have a high efficacy with reasonable toxicity. The high efficacy refers here to the higher dose re-irradiation. This is a systematic review on using SBRT for re-irradiation. And we can see on the left-hand side local control, on the right-hand side we can see the toxicity. So here again, we see a dose response dependency with local control, again showing that if we give the respective dose, we can achieve significant long-term local control. I think that's the important point. It's not, so somehow we need to break, let's call it the radio-resistant of the first treatment at least, because there it failed. Whether or not there's induced resistance from the first treatment, we cannot really address from this data. And again, we see a dose-dependent risk of toxicity. But here again, the time to recurrence, the tumor size, and the dose were relevant prognostic factors for overall survival. So here we have again a dose-dependent efficacy. And the toxicity again was moderate, considering that very high EQT2 doses had been given here with regards to normal tissue. A note of caution, of course, the target volumes were certainly smaller with SBRT retreatment than in the previous study with palliative re-irradiation of mediastinal tumors. Now, if we look at the prospective randomized trials and look at clinical relevant endpoints, and I put them here, what we see, not in every case, radiotherapy is the best option. It's a possible option if surgery is not reasonably possible. But here we have a situation where surgery is superior. We have not yet proven that with re-irradiation we improve overall survival, but we see an improvement in progression-free survival. For me, that's an indication that at least the local efficacy is maintained. But of course, we need to see the impact on overall survival to show the benefit on top of that. Maybe I would like to quickly pause and maybe ask you what's the proportion of palliative versus curative patients you see in your clinic, and how you clinically judge the prognosis, how you try to classify those patients, and whether or not there are situations where you decide against high-dose re-irradiation or re-irradiation at all, and why you do so. And please speak up to any of those questions, maybe first addressing the palliative versus curative patients.
Maybe someone would like to answer, or I could.
I think try to answer you first.
Okay.
And maybe
So,
someone.
in our clinic, we have a bigger proportion of palliative patients for re-irradiation than curative. But for re-irradiation, we had mostly cases head and neck, pelvic cases, and what else? A few cases of brain re-irradiation. Thorax, not. I would say that's all. How we judge about prognosis of such patients? First of all, if it's local process without distant metastasis, and the performance status of the patients is 0 or at least 1, it could be curative treatment for radiation. And if we see that the other options, for instance, chemotherapy could help in the future, or immunotherapy. So when we can treat patient for their local control, it would be re-irradiation. And in case if surgery is not possible. And which situation where you decide against re-irradiation, and why?
Maybe Marina, you did not mention thoracic re-irradiation. So we do a lot of, so our practice is basically reverse. We have a lot of thoracic re-irradiation, a lot of experience there. And we were rather reluctant to do so in the pelvis and the abdomen. So what's your major concern about the thorax?
Actually, we haven't a lot of cases for re-irradiation. I don't know why, maybe because we had a lot of advanced cases and we have no immunotherapy for a lot of patients, because in our country immunotherapy quite expensive. It's not for the government costs. And that's why these patients are not judged for the any re-irradiation at all.
Okay.
And for the last question, decided against re-irradiation, maybe when it's a short period between the courses.
Yeah.
Maybe it's some side effects that are not allowed us to provide re-irradiation. It could be not side effects according to the oncological disease. It could be other symptoms that not allowed us. For instance, if the patient has nephropathy or another situations. And if we talking about palliative, it's a COX-3. I would say that it's not the case for irradiation. Maybe.
Okay. So
Thank you.
basically, yeah.
I just want to say thank you, Marina, for answers. And maybe someone else want to discuss this question from a chat. Please raise your hands or switch on microphones and video cameras, and you can discuss. I don't see, unfortunately, raised hands. I think you can continue.
Yeah, I'm happy to continue. We can have some questions at the end as well. So, well, this should have come before. I don't know why I didn't switch that. I think what's important is that's also from the consensus. The decision for or against re-irradiation should not be driven by general radiobiological assumptions. And I will get to the radiobiological assumption as well, because we do not have a lot of data either with regards to efficacy nor recovery. We should look at the response to the first treatment and the benefit from the first treatment. So if there was a benefit and the tumor responded, we should be guided by that. Conversely, if the best response to the first treatment was progressive disease, we should not go for high-dose re-irradiation. So palliative radiotherapy might be an option, but we would be careful with that as well. Now, I would like to quickly switch to normal tissue radiobiology and also only quickly touch on what we probably know about recovery. And this is really the original slide by Kianang on his famous monkey study, where he could show that after a certain period of time, a lot of the previous radiotherapy given was recovered, and patients tolerated a higher, monkeys tolerated a higher cumulative dose than would have been possible in a single course of radiotherapy. And later, Carsten Nieder, one of my mentors when I was a resident, really developed this formula when we were analyzing palliative re-irradiation patients with regards to the spinal cord dose. And here again, we could see that if we apply this in the clinics, we could derive this very nice formula, which is very simple, just using the cumulative BED, having interval less than 6 months where we do not assume recovery as a risk factor, and the BED of one course exceeding 102 gray in 2 gray alpha beta value. And then we could assign points and also assign risk groups for the risk of radiation myelopathy. So here we have observed that preclinically and also clinically, and there have been later reports on that for stereotactic radiotherapy for the spinal cord and for the nerves and the plexus brachialis as well. Now, if we go to other organs, it's not that clear. And yes, for the brain in green, we see recovery and the evidence is quite strong. With other tissues, we do not see this as clearly. And especially the marked in red, we even see the contrary, that with previous irradiation, the tolerance is even decreased. And here there's very good preclinical data for the kidney. So if at all, we should assume a decreased rather than increased recovery. This doesn't mean that we see dose forgiven, but I'm not sure whether we should really talk about recovery, although it's iterated a lot in the literature, just to make the notion. We have other things to consider. Here again, this very simplistic serial versus parallel organs approach. But I think that this is much more relevant if we do our re-irradiation, what we need to consider, like whether or not to consider the maximum doses or rather the cumulative doses over an organ and the volume that has been exposed. And another very important effect or aspect is not only looking at the DVH, what the volume or how large the volume is that has received a certain dose, but also qualitatively how this dose is distributed over an organ. So it might be something completely different if the V10, the same V10, travels across the cross-section, for example, of a tubular organ or the spinal cord, or whether it's really only on the surface and not traveling cross-sectionally. And what we also know, especially also for serial organs, the smaller the volume, the larger the tolerance as well. And here I already mentioned that for the efficacy of the radiotherapy with regards to the tumor, but also here we should not be too driven by radiobiological assumptions like recovery, but really look at what is the benefit and how we judge the risk of the current irradiation, taking the previous dose given into account. So what we do not know is what the subclinical damage causes. So we have some indication for the spinal cord, but we have not a lot of knowledge, for example, if an organ has been exposed to radiotherapy and we would investigate it, for example, with a bronchoscopy or rectoscopy, and we see no changes of the mucosa or endobronchial from the previous radiotherapy. Does this mean recovery from the previous irradiation? Can we give full dose or not? So these would be interesting questions. Or should we adjust dose if we see changes in bronchoscopy or rectoscopy? These are all questions that have not been addressed. So I stated this already. If we look at serial organs, we should more concerned about the maximum doses. We should not be obsessed, but this is the high doses play a role, not only the Dmax, but maybe also like the volume of 0.51 cc. And for serial organs, it's really the irradiated volume that's relevant. So basically, the radiobiology also applies for re-irradiation. And for tissue-dependent recovery or dose discount, these are questions of ongoing research. These are more or less rather mechanistically addressed by, for example, the dose discount. That's sometimes even an arbitrary factor, not meaning that this concept might not work, but we need a better understanding on how this to apply in clinical practice. Now, we have to deal with a lot of uncertainties when we do this dose accumulation. And one of the first is the dose, the image registration. So do we do it in a rigid way? Do we do it in a deformable way? Both methods have pros and cons. And it's not an easy question to say you have to use this or that question. I will come to that later. And then it's not always the question which method to use, but just looking at this case, and if it's a nasopharyngeal re-irradiation or it's a larger volume re-irradiation, and that's not a re-irradiation case. It's a case taken from an adaptive study where we want to accumulate the dose. So basically, we would even need to consider multi-segmental or even organ-based registration to get the true dose distribution or the true cumulative dose distribution. So just simply using rigid or deformable may not be the answer. The dose recalculation, currently it seems that I would call it the EQD2 has won, but there are concepts like the general equivalent uniform dose or the biologically effective dose, which has actually been used for CNS tissue and all those cumulative dose calculations. And then next uncertainty is which alpha beta should we use? In the consensus, we were rather vague, I would say, honestly. We gave a table. In Zurich, the way we do it, we do not assign a alpha beta for the tumor because the tumor is not of major concern with regards to the cumulative dose. There we have the major concern, what dose can we give in the second course? So we only use alpha beta for normal tissue, and there we are very pragmatic. We use two for CNS tissue and the optic structures, and 3 for everything else. That's maybe very simplistic, but maybe in the end, it's not about the question what's radiobiologically right or wrong, but which approach, which model approach, or which consistent approach gives reasonable and safe results. And here again, we also need to look at what's the assumption. Do we assume a recovery or not? For me, it's not the question what's right or wrong, but you need to develop a framework where you develop experience, you validate it, and you're confident that it's safe to do so. So there's no definite consensus. We have institutional experiences on that. And I think that right now with the ASTRO and RECOG activities, more and more alignment is coming onto the field. Here, just an example for to compare rigid versus non-rigid. So rigid, there you have, if everything stays the same, maybe rigid is the most robust because you're not deforming any voxels or how to map the dose. It's not that good for moving organs. It's difficult if the patient positioning has changed, if the anatomy has changed. Here, what you can see here is you have the coronal previous CT and the same CT, and suddenly either the patient had a pneumonectomy or has suddenly a pleural effusion. This changes the anatomy quite considerably. And if you then use, for example, deformable image registration, the algorithm might even fail and give you an artifact like that. So these are factors to consider when we do the dose accumulation. And sometimes it's even not anatomy-based, but it's also patient individual choosing of what is the optimal registration method. Now, with the uncertainty considerations, I already pointed some issues out, but just to summarize, it's not that it's not possible to work with these uncertainties. And some of the other uncertainties is also that maybe sometimes the previous dose distribution is not available in electronic format, and you don't even need to worry about what I just talked about, but you worry about, okay, what has the organ or the organ at risk actually received? But if you have a chance to reconstruct it somehow from simulation field or portal images, then you can have a conservative approximation for computer calculated 3D dose summations. And also, if the dose distribution is not available, at least a conservative approximation is that the area of concern might have received the original dose prescription. This might be too large in some areas because you don't know the portals. It may also be that in some instances it's underestimating the doses, because in the old days, sometimes with a single field or APPA fields, you may have had like not only 107%, maybe sometimes even 120% in some areas, but still it's safe. And if the previous dose distribution is available electronically, we really mandate that you should do at least a dose summation to get, as a first impression, the overlap. Is there overlap at all? Sometimes you will be surprised, and this just happened to me today, that I did not expect a significant overlap. And when I looked at the plan, I was really surprised, and I thought, okay, I didn't think this carefully through. There's definitely more to consider than only radiation dose. Here, it's just a slide on carotid blowout. Personally, I think this is overrated, depending on the studies you're looking at. In head and neck radiotherapy, I'm much more concerned what we induce in a patient, not as a life-threatening complication, but a quality of life impairing complication like swallowing structures or chronic ulceration and so forth. So here, there are patient-related factors and dosimetric factors that might drive the risk of a carotid blowout. And I think we need to clinically judge whether or not there's encasement or invasion. Personally, to me, that's the highest risk factor. And of course, those somehow came up as an independent factor. But I'm more concerned that if there's high cumulative dose to a normal, non-invaded, non-changed vessel, that's a very, very late event that we see a carotid blowout, and really this encasement invasion is the major driving factor. And here another study to consider comorbidity. There we have not enough knowledge, unfortunately, but here a study with CNS re-irradiation, where they raised the concern that diabetes might indeed increase the risk for radiation-induced toxicity. Yet the difficulty is we still do not have guidance that if diabetes is present, what should we do? Should we adjust the dose? Should we give lower doses? So it's really difficult. For me personally, I would take it into consideration, especially if there is CNS tissue involved. I would not be as much concerned, for example, with vertebral compression fracture, if it is in an area that's not dangerous. Here, this is just a slide I put together at some time to try to show the individualized approach, how we can select techniques. And what you basically see, difficult to say whether there is really a superior method to one or the other. Personally, I would judge this comparison table rather with regards to what is available in your individual institution. So if you have a brachytherapy service, and especially with interstitial and image-guided brachytherapy, I think that's a very nice and very valid option to do re-irradiation. Now, some quick words on how to do dose accumulation. So we do the registration and we really look out. We start with a rigid registration. In most instances, except for the thoracic region, we do not use the formal registration. We do the EQD dose calculation and map it on the, we do recalculate in EQD2, map it on the new CT. And with this dose information, then we contour also the new structures. So we contour the GTV, and then we know we have the isodose, certain isodose curves transferred as volumes. I do not adjust my PTV based on that, but it's really already while I'm contouring, I'm thinking, what can I reasonably prescribe? We have institutional guidances for cumulative doses. And then we optimize based on these, to map the dose on the new CT, and then sum up the doses in a final step and try to acknowledge any uncertainties if there are any. Like I said, with regards to positioning and changes in the position of organs at risk. I think the most important is that if you develop a workflow, you need to be consistent. You need to be able to reproduce it later or know what you've done. And you need to build in plausibility checks, maybe even with point dose estimates and recalculation, and not always fully relying on what the registration or the optimization spills out. So there's no standard on dose accumulation. These are three methods. Method one is the safe method. So you use the same Re-RT constraints for the first and for the second course, but you deduce from the current set of parameters, you deduce or subtract what you have already given, and you only allow the remainder of the dose. So you will never exceed the Quantec or high-tech criteria. That's perfectly fair to do so. And the second, third methods are methods where you apply, where you either apply a dose discount like in method 3, or you don't apply dose discount. In both situations, you may exceed the Quantec and high-tech, and that's important. With method 2, you have the advantage that you really know what you have given as a numerical dose. With the third method, you have a discount factor, and you always need to state what discount factor you have applied for every organ. Maybe for the sake of time, I'm not sure whether we would like to have these questions or whether I should proceed, Marina.
Yeah, okay. For re-irradiation, we use IMRT-VMAT. And in some cases, we have brachytherapy. We can use brachytherapy. What kind of image registration do you perform and why? We have daily IGRT, and it's the standard for our house zone, because without IGRT we couldn't start treatment.
And do you do EQD2 calculation, or do you do physical dose summation, or what method do you use?
We use a QD2 calculation of both courses, and the sum dose we evaluate and make decision according to the dose to the tumor and the dose to the organ at risk. And sometimes it's compromises about the decision what dose we use for the target.
Okay.
What organ at risk toxicity most concerned? Okay, we are mostly concerned about the serial organs. Oh, sorry. not serial, serial organs like spine, bowel, vessels. Mostly it's spinal cord, brain stem, optic chiasm, optic nerves. It's the most
basically, Marina, we have a similar approach. With spinal cord and brainstem, we have the data on recovery, and we can sometimes, those are not necessarily the organs that pose the limits. We're very careful with the optic system. We are careful with the esophagus. We're careful also with the bowel, and then with all other organs, we try to push the limits currently, but we're still also in the exploration phase. Yeah.
Okay, thank you.
Maybe here, again, consistency, reproducibility, and documentation is key, that you know what you've done previously. So we have here like a decision situation. So if we have a type 1 or type 2 re-irradiation, we always here, because we think that the organs at risk constraints from a de novo course will be exceeded. And then we have a stepped approach when to compromise the PTV or not, and when to change the prescription dose. So in the first instance, we allow a PTV compromise as long as we have a minimal GTV or PTV coverage. And if this is not respected, then we change our prescription dose. So for example, we might tend to give 10 times 5 gray, and we see that with this cascading, we cannot keep a reasonable coverage like here. We might only then we switch to 10 times 4, for example, schedule. But I think it's important to have a rule of thumb how to proceed when you cannot respect the organs at risk, or if you have institutional limits for cumulative dose, well, and when you start to compromise your PTV, and when you start to adjust your prescription. I think that's important. Well, we should calculate the biologically effective doses. And here, especially when we use different fractionation, we had this. And if established dose constraints of an organ at risk are not exceeded in the dose summation, re-irradiation can be deemed safe. And this refers to the first method of dose accumulation, where you just use your de novo criteria, subtract what you have given in the first series, look what's left in the second series, and then you know you're safe. Also very important, put in your records what you have done, so that you really can learn from it, but also that you know what you've done when you're revisiting this patient. Maybe very quickly showing a case where we have a type 1 re-irradiation after Pacific stage 3 radiochemotherapy, high dose re-irradiation with 66 gray, and then we have lymph node recurrences with multi-station involvement. And we opted for re-irradiation in this case here, that we say, okay, it's radiochemotherapy. We had here this situation with the re-irradiation plan. We singled out the respective lymph nodes. We had GTV defined of diffusion with PET-CT. Normally, we don't use CTV or elective volume. Some ITV margin, but very small PTV margins for daily cone beam CT. And in this situation, because the patient already received 66 and it was ultracentral, we went for a hyperfractionated approach like this 2.75 to 55, not a stereotactic approach. Now, if we look at what we've actually given here at the proximal bronchial tree, we were here in the re-irradiation plan at 68 gray. And if we look at the sum plan, we were somewhere between 122 and 128. If you look at the consensus-based publication, those consensus are all below what we have given. But we also looked at, for example, SBRT trials for secondary lung cancer in the de novo setting. And here already higher doses had been accepted to the proximal bronchial tree. So maybe these constraints are too conservative. We don't know, but we exceeded those. And if we look at this re-irradiation with high dose SBRT in the central or intracentral region with 3 to 5 fractions, high toxicity rates compared to a more protracted risk-adapted SBRT approach. And here it's important to say that it's more cautious fractionation with ultracentral or central re-irradiation reasonable. We do not have detailed dosimetric data, but we are very careful with SBRT in the central or ultracentral region. If so, we tend to give 10 fractions, or we switch to the 2.75 to 55 gray. If we look at the accumulated dose in the lungs, here, the mean was around 25 gray, for the left lung, even 40 gray. It's again, either higher than published, or the groups couldn't come up with a consensus. But still, we need to consider two different endpoints. It's either pneumonitis or fibrosis and impairment of lung function. That's important to consider. And the D mean is a parameter for pneumonitis. It doesn't tell us about the lung function. What we know that from this study, that in-field re-irradiation has less pneumonitis grade 3 than out-of-field re-irradiation. And this is something we have observed in our data as well. And not surprisingly, that in-field chest wall pain and rib fracture is higher in the in-field re-irradiation situation than in the out-of-field re-irradiation situation. So basically here, I would not be as much concerned with pneumonitis compared to this situation. And at some point, we might here even see impairment in lung function because lung tissue has been become fibrotic. With the esophagus, again, here we were at EQD 269 gray, and here the consensus statement varied. So we were somewhere at the upper limit of what has been, or even exceeded what has been published. But I would tend to say it was within range of recommended cumulative dose constraints. And here there's also nice data, as I showed you on the radiobiological principle. You really need to look at the transversal and cross-sectional dose distribution. And here they try to, they put rings on the esophagus and looked how many of those rings and volume of those rings has received dose, just to have a judgment on the length of the esophagus and also the cross-sectional elements. And here again, the cross-sectional accumulated dose was relevant. So this is also something that you can qualitatively judge from the plans. Also with the plexus, here we were at 95 gray, exceeding what has been as a consensus. And here, higher than the international consensus, but only one strain affected. And we have re-irradiation data from head and neck where this still might be within the safe limits. And you also see that we have differing guidance, maybe for the thoracic re-irradiation compared to the head and neck re-irradiation. And here also, we have clinical data where they collected it and tried to come up with low, intermediate, and high risk, depending on the interval and the dose maximum. And I think that's also quite relevant. And here we were in the situation of less than 2 years interval and just at the threshold of 95 degrees. But here the cumulative dose and the interval were relevant to put those in these risk categories. Now, if I put this here in perspective, only spinal cord was really respected in our case, and the esophagus. With the other organs, we were well above, and the patient actually tolerated this very well. We have, that's a rather outdated publication of ours. We are in the process of updating this. More importantly, not only focusing on the maximum doses, but also look at the volumes that have received a certain dose, and looking at the numbers that those patients have received. So with 5 or 7 or 1 patient, we cannot really make some conclusions. And if you see, almost all these parameters were exceeded in the case I've just showed you. We tried to reevaluate this right now. Here you see the respective change. The patient had only some cardiac symptoms, which were not definitely able to explain by our radiotherapy, and an asymptomatic pneumonitis. Maybe I would skip this and wrap up with my talk. Very important, we have this E2Radiate platform where we have a re-irradiation cohort. Everything is allowed, including protons. Soon we will also open brain and head and neck. So we've covered all areas of the body. Primary endpoint is local recurrence. We ask a lot of questions that are not directly related to the cumulative dose, but we will also collect all radiotherapy treatment plans and make modeling analysis based on that. We hope at some point that we can attach trial within cohorts and then also be able to randomize within this registry. Very important, we have a very active astrophysics group that address all these issues you see here. And this has then also led to this initiative to team up with the American groups. And this is really an international effort, like Quantech or Hightech or Pentech, and maybe we will at some point have Retech, really to have international consensus. And for me, very important, we have this ASTRO focus group set up, and it was approved by the ASTRO. We just built the focus group member group. We'll meet at ASTRO. And that's really nice because we will follow on the webinar. We will have an ASTRO journey at the ASTRO conference that's depicted here. We will have a meet and greet on Sunday. We will start with a webinar, and we also will submit a dedicated ASTRO course on clinical practice of re-irradiation. And with this, I would like to end, and I'm happy to switch to your cases, Marina.
Okay, thank you very much, Dr. Andratschke, for such brilliant lecture and for recommendation for such challenges treatment. I'm pleased to present re-irradiation cases with you, and you're the most renowned expert in this field I ever know. And I listened last year the course of ASTRO that you presented. So I have a lot of information from that time and today. And also I'm grateful for their warm introduction to Ruslan, and I would also like to express my sincere gratitude to Professor Natalia Kovalchuk and Help Ukraine Group for organization such a valuable and insightful course for Ukrainian specialists. And it's very important to our country, and we have a lot of we send a lot to our colleagues. So please start with me with my lecture. I'm sorry. I'm just try to share. Have you seen my screen?
Yes, we can see, but in not presentation mode.
Just a second, because I'm confused with the.
Do you have a few monitors?
No, it's just one, but I clicked somewhere. Sorry.
Try to click in right lower corner.
If I stop sharing, just
Oh, okay.
for a second. Not full screen. I'll change to speaker now. Okay, it's somewhere view. And now, is it okay?
We can see your presentation, but not in presentation mode.
And now, is it okay?
Let's wait. No.
No. Just try again. Sorry for the delay. And this one.
Yeah, it's
Yeah,
good.
okay. So, my first case of oropharyngeal re-irradiation. This case involves a 53 years old gentleman diagnosed on May 2020 with squamous cell carcinoma of the oropharynx, clinical stage T4A and 2C, MX, and grade 2. Initial imaging CT revealed that it's the 3.5 centimeters tumor in the right oropharyngeal wall, extending into the base of the tongue and epiglottis. Multiple affected lymph nodes at levels 1B, 2, 3, and 5, mostly in the right side. And the largest lymph nodes were at level 2 bilaterally. Initial treatment that he passed in the 2020, it was neoadjuvant chemotherapy, TPF protocol, 3 cycles. With a positive clinical and radiological response. However, dysphagia developed post-treatment. Subsequently, he received definitive chemoradiation. In total dose 70 grays in 35 fractions. To lower risk areas, he received 54 grays in 27 fraction, and high risk areas, sequential boost 16 grays in 8 fraction. That time we had only 3D conformal radiotherapy. So the treatment technique was Bernier, with dividing the fields into parts, upper part for the oropharynx and upper lymph nodes, and lower part for the 4 and 5 levels of lymph nodes. Concurrently, he received chemotherapy, cisplatin, 100 milligram per square meter, 1 cycles every 3 weeks, and totally he received 3 infusions. And he finished chemoradiotherapy in November 2020. On this slide, you can observe color wash of dose distribution of plan sum for the initial treatment plan, where the maximum dose reached approximately 76 grays. It's in the right side. Here, dose distribution and DVH analysis for the boost, where we see that the hottest space was in the right, with hot spot 110 grays percent. On some DVH, we see that while those constraints for the spinal cord and brainstem were within acceptable limits, both parotid glands received unfortunately higher mean dose, but it was expected outcome because of using 3D conformal radiotherapy. And after 3 years, in July 2023, Following intubation for cholecystectomy, the patient developed discomfort on the right side of the throat, and MRI revealed a recurrence confirmed by biopsy, and it was squamous cell carcinoma G2 and PDL positive 2%. Patient underwent three cycles 5-FU cisplatin and pembrolizumab with positive clinical and MRI response, and after that additional 3 cycles the same protocol. And in December 2023 on MRI it was stable disease. So that MRI showed us that it was the cavity in the right oropharynx with a tumor measuring 18 millimeters to 35 along the cavity wall and infiltrating surrounding tissues. Additionally, it was suspicious second lesion up to 2 centimeters in the right hypopharynx, and it wasn't any lymphadenopathy detected. So you could observe the irregular shaped cavity and the tumor in it. After tumor board, patient received consideration that firstly it was suggested surgery, but maxillofacial surgeon told us that R0 resection impossible because it couldn't be reached during the operation. And patient was suggested proton radiotherapy, but he refused because of financial toxicity of this treatment in other country. In Ukraine, we haven't proton radiotherapy. So the final treatment plan was proposed re-irradiation of a recurrent tumor in total dose up to 60 grays in 30 fraction with radiosensitization of pembrolizumab. It was suggested 2 cycles during the radiotherapy. And we planned re-irradiation using VMAT with daily IGRT for precise targeting. And here it's the contouring. So it was with MRI fusion, and you can see that it was tight margins from GTV to CTV 5 millimeters and from CTV to PTV 3 millimeters. The symmetric analysis of DVH presented here. We achieved maximum dose for the first priority organ at risk for brainstem 17.7 grays for the second course, and for spine 5.1 gray. So this values remain quite low to the treatment volume for this patient, as it's doses 60 grays to the tumor. And we assessed the cumulative doses from both radiation courses. To spinal cord total dose from both courses 46.5 grays, for brainstem 57.7 grays. Also, we find such article in the literature. It's our Chinese colleagues that provided analysis for total dose after 2 courses of standard fractionation radiotherapy for nasopharyngeal carcinoma, and they report in maximum total doses for brainstem. It was almost 112 grays, and the mean dose almost 54 grays. In comparison, our patient brainstem maximum dose 57.7 gray. So we decided that it's our planning was quite good. And spine in their case was 75.5 grays, its maximum doses, and mean dose 32.8 grays. So in the lowest part of this slide, you can see that the average time from primary diagnosis to local recurrence was 2.8 years. In our case, it was 3 years, so it was comparable to our case, this article. In follow-up, this patient finished re-irradiation in February 2024 with quite low side effects. It was dysphagia G1, mucositis G1, epitheliitis G1, and xerostomia G1 and 2 because of the damage for the parotis from the first course. But in the March of this year, he faced with the first episode of bleeding from a post-radiation ulcer on the lateral oropharyngeal wall. But on MRI and endoscopy and biopsy, no signs of malignancy. And it was after the next course of pembro, after the chemo radiotherapy in this year. He followed the next cycles of pembrolizumab. Totally, it was 12 cycles and 4 after radiotherapy with stable MRI dynamic. But during the 6 months after re-irradiation, he has 3 episodes of bleeding. So it was provided gastrostomy and tracheostomy, but on MRI there wasn't any signs of progression. No option for reconstructive surgery, and immunotherapy was stopped because of these complications. So, according to this case, I have a list of questions for the discussion with Dr. Andratschke. And the first one, do you agree with the proposed treatment plan? What modifications, if any, would you suggest? How should normal tissue tolerance be properly evaluated in this case? Given this, we had previously 3D conformal radiotherapy and now WMAT plan. What is the priority ranking for the organ at risk, and should additional systemic therapy or immunotherapy be considered concurrently with re-irradiation? And does prior radiotherapy increase the risk of bleeding in this patient, or it could be like side effect of immunotherapy as combination of the re-irradiation?
Marina, thank you very much. Maybe the first question, from what I heard, and we discussed the case previously, and this is the second time, I still fully agree with your plan. And of course, it's always difficult from a distance, but from what you explained, I also can acknowledge the target volume you delineated. Probably, so if I would have added something, if a PET-CT would have been available, maybe this could have been a possibility to have a better understanding what of the MRI changes is really active tumor. With regards to the fractionation, with this type of volume in this area really traveling along the right side of pharyngeal wall, I would have also opted for this fractionation. Maybe one could even argue, why not use hyperfractionated? We have this discussion also in our department. Unfortunately, we do not use it very often, but that could have been an option. I don't think that the difference between normal fractionation and hyperfractionation might have changed the outcome with regards to bleeding, but I will make the case later. I think you have evaluated the normal tissue tolerance quite nicely. So you try to get some guidance from the literature and also try to match your patient in what has been done, for example, in the Chinese colleagues study. Yeah, I'm maybe I think we discussed this 3D and VMAT as well. We do not tend to mix those techniques. So basically, we do all our re-irradiation as VMAT, and we really try to guide the dose by the organs at risk tolerance and accept PTV compromises, for example, to respect or to spare or to better guide the dose. Yeah, with regards to both parotid glands, so basically most of the dose is on the right-hand side due to the re-irradiation, and you will not have a lot of spillage on the left-hand side. I think that's a problem if you have cumulative doses at all. I'm not sure whether you could have avoided that. There we might need to look closer to the plans. So maybe also going for a PTV compromise as long as the GTV is well covered might be an option, but that's just speculation. Priority ranking of the organs at risk, difficult to say. So for example, with the spinal cord and brainstem, I think you were quite safe. And other organs at risk, well, we don't know about the constrictor pharynges. Maybe this is something you could have looked at, but on the other hand, it's in the target volume, basically. So I'm not sure if you could have changed something with regards to your treatment plan. I think it was properly done. Also, the dose accumulation, you had a lot of thought put in there. Should additional systemic therapy or immunotherapy considered? The patient has already received Pembro, and what we don't know, so he responded beforehand, then you gave radiotherapy, and then you restarted Pembro. I don't think that this patient would have needed more systemic therapy. We discussed that already last time. Now you were presenting the case a second time. As the patient has very well responded to the local treatment, and it's a local disease, probably, and afterwards we always know better, but probably as the patient was really only having a local recurrence, no lymph nodes, no spread anywhere else, maybe I would not have continued with the systemic therapy. Personally, I think if it's about local control and local regional control, we are overestimating the effect of systemic therapy and should rather rely on the bulk effect of the radiotherapy.
Okay, thank you. Our thoughts was that Pembro could affect the episodes of bleeding because our previous cases of re-irradiation were without any systemic and immunotherapy during this course, and it was quite successful. And even with the nasopharyngeal carcinoma, with the interval of 1 year after the first treatment of 70 grays, we give 60 grays, and this young 35 or 37 year patient under follow-up in the Turkey, because he relocated when the war started, and 3 years here under control. And it was our first case when we couldn't understand what could affected these bleeding episodes. So we would give it in the mention in the notice in the future. So thank you very much for your comments. Nicholas,
Maybe Marina, maybe last comment. Of course, now it's full speculation. I don't know what the true effect of the pembro with regards to the bleeding was, but well, of course, considering the volume, considering the re-irradiation, this could have happened also with re-irradiation alone. But as you said, it's not that a frequent event, or not, well, it's a typical side effect, but not that frequent that I would say, okay, I would have expected with radiation alone. Now you have experienced that with pembro. There's still the possibility that it was just unfortunate that it just happened in this patient with this combination. But if it's really local, I would not give. I would try to, with the next patient, maybe I would be careful with pembro if it's not needed from a risk profile out of scare for distant metastasis. Yeah. Okay.
Okay. Yeah. Thank you. I agree with you. So let's continue. So the next case, it's the case involves a 47-year-old lady diagnosed with cervical squamous cell carcinoma in December 2018. She underwent surgical treatment that included radical hysterectomy, resection of upper third of vagina, and pelvic lymph node biopsy. And 3 pelvic lymph nodes were positive for metastasis, 2 on the right and 1 on the left. After the surgery, her diagnosis was squamous cell carcinoma of the cervix, T1B1, PN1, M0, grade 3. Post-surgery, she followed radiotherapy in Belarus. She received adjuvant radiotherapy, in total dose 50 grays 25 fraction, with concomitant cisplatin 50 milligram per square meter. She received 4 cycles and sequential paraortic radiotherapy in total dose in the same doses that for the pelvis. She finished her treatment in February of 2019, and in 5 years she experienced with the recurrence confirmed on MRI. Recurrence in the left obturator region, and you can see it in this scans. So it was irregularly shaped solid mass with unclear borders. With measures 26 on 19 on 18 millimeters, and with invasion of mesorectal fascia. This tumor was very close to the left obturator muscle and sacral plexus. So the patient underwent laparoscopic surgery and resection retroperitoneal pelvic tumor on the left, and pathologically it was confirmed recurrent G3, but R1. So surgical margins was unclear. And on our tumor board, it was proposed re-irradiation to recurrence bed, 40 grays in 20 fraction. We made the plan according to the fusion with MRI, and you could see that we controlled the tumor bed with MRI with the tumor, so it was pre-op MRI. CTV, it's tumor bed with surgical clips, and PTV, it was margins from CTV from 0.8 to 1 centimeter. You could see the volume on these scans. And as we know that this area very frequent has recurrences, it's almost 41% after their treatment. So for this, on this slide, you could observe DVH comparison. We create two plans with VMAT and 3D conformal radiotherapy. The best target dose that we achieved, and two modalities show different dose distribution for organ at risk. And here you could observe that the doses to the bowel higher dose was maximum 40 grays for the bowel on 3D and 17.4 on the VMAT. And but on VMAT it was higher dose in mean dose to the bowel and to the rectum. And I added the bowel contour. You could see it's the white one. So it was quite low because we discussed that it could be the main priority to the bowel in this case. But as it was quite low, so our attention was paid to the rectum and to the bladder. So this plan's quite similar, I would say. Okay, and the next case, it's case quite same, but just a little bit different. It's adenocarcinoma of uterus. PT2NXM0. Patient was treated in 2018. After the surgery, she passed the adjuvant pelvic radiotherapy, 46 grays on cobalt machine with additional brachytherapy. But in 5 years, she has recurrence in the left common iliac lymph nodes, and the volume was bigger than in the previous case. She passed 3 cycles of chemo, Taxol with cisplatinum and doxorubicin with cisplatinum, with tumor progression on CT. And we treated her with the external beam radiotherapy, 40 grays in 20 fraction as re-irradiation. She completed treatment in May 2023, and 2 years she under follow-up without no signs of the tumor. My questions about this treatments, what treatment strategies can be considered in these cases? For instance, is a surgery was enough, or chemotherapy have to be immunotherapy, or irradiation was good after the surgery? What target volume margins and dose could be recommended for irradiation in pelvis? Because in the both cases we use 40 grays in 20 fractions. Could it be higher or lower? What dose constraints should be carefully evaluated to minimize toxicity in these cases compared to the head and neck cases? You are muted, Nicholas.
Yeah,
You are
that's
muted.
okay.
I'm sorry, I always mute myself. I'm still figuring out whether I should answer those 2 cases differently. Probably, so the first case I would interpret as a pelvic, like central or pelvic sidewall recurrence, rather local recurrence, not a typical lymph node. The second one was a lymph node. Maybe there's a different risk with further spread along the para-aortic axis, or maybe even distantly. Still, we do not have really good data with regards to combination with systemic therapy, for example. The first case, very interesting. We discussed it last time. I'm not sure whether in every case I would have tried to operate on that, because it turned out to be difficult to resect, and it turned out to be, I think it was wasn't an R1 resection, right?
Yeah.
And that's always difficult if you operate and then you get something like an R1 or even R2, because then post-operatively it's more difficult to delineate your target volume. So if there's a concern of taking it out R0, one might even consider like a preoperative radiotherapy strategy, so that you can use lower doses. For example, the 40 gray is already a lower dose, but this might be sufficient, even though it turns out a marginal resection because you already covered the tumor bed with dose. So this could be one point of discussion. With chemoimmunotherapy, who I think the data is not strong enough. And again, for me, it's an important point whether or not it's really a local recurrence of the primary or like a pelvic sidewall recurrence, or we need to consider higher risk for distant spread. With regards to target volume and margins, I think with the second case, I didn't see an MRI scan. I'm not sure whether you used that for delineation, but for pelvic and abdominal recurrences, I would definitely use MRI for delineation, and maybe even if you have the availability sometimes of a PET scan, if you in MRI are not clear always whether this is a fibrosis or also tumor recurrence. Because especially here with the psoas infiltration, maybe you could have had a better demarcation. Of course, you always need to consider that this muscle is broadly infiltrated, but it's also possible that it was just elevated and displaced by the tumor. And maybe with MRI, you can better define the GTV. There's an ongoing debate on whether or not to use a CTV. We're not decided ourselves, but mostly we do not use a CTV. The reason for me is, and I would also use a very tight PTV margin, what you can ascertain with your image guidance and what your institutional limits are. For me, it's more important to get the dose in the GTV and not to have an excellent PTV coverage. That's why, for example, in those two cases, well, not the post-op, that's the first one, the post-op, but if the first one would not have been operated, I may have opted for SBRT strategy. So to have a higher dose in the GTV and then a gradient to a lower dose to the PTV, and then adjust the dose according to the organs at risk. Because what I sometimes see, and I even saw in our department when we started out, that people were very much focusing on the PTV coverage so that everything was nicely covered by the dose, and rather, if they saw it was not possible, already adjusted the prescription dose. So you accepted a lower dose in the tumor than at the border or outside because you were concerned about the organs at risk. So I personally would rather make a PTV compromise and maintain as much as a high dose as safely possible. And then your margins are not that important anymore. So you take your margins you would take to assure that you can, that's your institutional limits. And then everything else is guided by the organs at risk, and you accept the PTV coverage. And as soon as you cannot maintain with the dose you intend to give a reasonable GTV coverage, then you can reduce your prescription dose. And we rather tend to give inhomogeneous dose, like higher doses to the GTV, lower prescription PTV dose to maintain high biologically effective dose. And basically both you could have achieved in your cases, because within the tumor it doesn't matter. The psoas muscle tolerates quite a lot, and then you just adjust to the bowel, you see.
Okay.
In those cases, we are mostly concerned about bowel toxicity. And even with the pelvic sidewall, not so much with the ureter. You can put a pigtail in there. So it's not that we neglect it. Sometimes we are concerned about the nerves. But with this iliac recurrence, basically you could have given a quite high doses without sacrificing any risk to the bowel.
Okay. We evaluate that it's our prime attention. So as you can see, it's quite low doses to the bowel. It's a wide curve.
Mm-hmm.
The mean dose 1.3 to the 3D, and to the VMAT mean dose 2.1.
Yeah, I think basically, I think we discussed that already. These are the doses from the re-irradiation, and you need to assume that you already gave like 40 gray in the first series. I think you already exceeded what we would give in the first situation, but
Actually, we haven't any information about the first course because it was in Belarus and another country, and we haven't these plans. So we decided that the bowel received the highest dose of 50 grays, and our doses was as much as lower.
Yeah, fully agree with this approach, because that's the safe approach, to assume that the bowel has received a prescription dose and still you're higher than what we would give normally in the de novo setting. But I think with the time interval and well, basically I would have probably accepted similar doses. I would have sticked with the VMAT plan only, and then tried to maybe well, with 70 gray max, I think you're still safe. So maybe I wouldn't even have adjusted the PTV. I wouldn't have done a PTV compromise, as I alluded before. So I think with the assumptions you made and the accumulation, it was reasonable to do so. Yeah, fully agree.
Thank you. Thank you very much.
It was your last case, yeah?
Yeah.
Yeah, so thank you to both lecturers for great presentation and interesting cases. Maybe someone from audience have questions. You have a great chance to ask. Please raise your hands or just switch on microphone. I don't have questions. Maybe I want to ask both lecturers. What percentage of patients who have undergo radiotherapy, initial radiotherapy in another hospital, and who need to be radiated by you have electronic plans? From your
Sorry,
experience,
have no plans.
what percent of patients have electronic plans? It's a
Okay.
yeah.
Okay.
Because I know that in
Marina,
Ukraine it is a huge
yeah.
problem.
Yeah, Marina, first, please. Yes.
Yeah, okay, thank you. We every time we try to understand what center provide the first treatment, and we try to communicate with the doctor or other colleagues in this center to receive these records. And according this data, we provided the next course. But if we haven't, like in presented case, we evaluated that the organ at risk received the maximum doses according to the prescribed dose to the tumor.
But typically it is a low percentage, yeah?
No,
No?
if we ask, we receive information. If not, we haven't possibility to get this information.
Okay, thank you.
Yeah, fortunately, we're in a situation that that Swiss centers can provide plans in DICOM RT compatible format. What can happen is every now and then that we see adults being re-irradiated for new primaries when they had irradiation like 20, 30 years ago. And then we're in the dark as well. And basically, Marina, we do the same assumptions and we have the same approach that you take. And I think it needs to be pragmatic, and it needs to be with assumptions that are safe so that we feel comfortable doing so. Fortunately, we have all the plans. On the other hand, it means we can do all the summation, we can do all the calculations, and suddenly we see, oh, how high the doses we give. So basically, we also had the discussion at the international consensus that sometimes we had clinical practice of re-irradiating, and possibly we gave much higher doses. And now that we see what we give, we need to be careful that we are not overly cautious and suddenly are not willing to give more than like 80 Gray to the proximal bronchial tree. So I think this is something what we are just trying to learn.
Yeah, thank you. Any other questions? I think no, so thank you for great presentation again. I think a recording of this presentation will be very useful for our colleagues in their future practice. I see some thanks into a chat. So thank you and have a nice evening.
Thank you very much.
Dr.
Thank you very much,
Andratschke,
Marina.
for
Thank you very much.
collaboration. Thank
Sure,
you.
Ruslan. And also my best wishes to Natalia. Thank you for having me here, and more than happy to stay in contact.
Okay,
Yeah,
thank you very much.
Bye.
Okay.
Thank
Have
you.
a good
Bye-bye.
evening. Bye-bye. Bye-bye. See you.
Bye-bye.